Hello, everyone, and welcome to Aging with CF. My name is Melissa Shiffman, and I'm an adult with cystic fibrosis. I will be moderating this session this afternoon, and I'll be introducing our other speakers in just a moment. The session is also being recorded and will be available to all registrants after the event on the CF Foundation YouTube channel. Before we get started, I want to go over a few items related to the technology and how we can all interact. First, closed caption is available. You can turn them on by moving your mouse over the video feed and clicking the CC icon that will pop up at the bottom of the screen. Please make sure you're in Google Chrome to utilize this feature. Under the stage on the right, the stage tab on the right side of your screen, you'll notice the chat for everyone who is in the session. If you are in the event tab chat, that is for the full event and not specific to this session. So be sure you're in the correct chat to engage with others in this session. We will be taking audience questions during the session. We encourage you to submit your questions at any time into the Q&A box. You'll find the Q&A by making sure you're in the stage tab on the right side of your screen, then select Q&A. We will do our best to answer as many questions as possible. You can also like questions submitted in the Q&A by others, which will help us prioritize based on popularity. Excuse me, it's cherry blossom season, my allergies. Make sure you use the Q&A box to submit questions, not the group chat where questions may be missed. You won't be able to answer we won't be able to answer questions about the individual diagnoses or treatment plans, and we encourage you to use the information you learned today to have conversations with your care team. If you have any tech problems during the session, you can visit the help desk by clicking the Expo icon on the left side of your screen. CF Foundation IT support are there to help if you are having any trouble during the event. Now let's get started. I am very excited to be moderating this panel. I was diagnosed with cystic fibrosis when I was 5 years old in 1978, after the mystery of my brother's chronic illness was solved by a sweat test. Back then, life expectancy was 12 years old. My brother died months before he turned 17. Somehow, I'm still here at 48 years old. I went to college, grad school, worked until I couldn't work anymore, got married, and gave birth to 2 children who are now 14 and 17. I thought up this session because for the past few years, I've noticed issues in my body that make me question, is it my age or is it my CF? A lot. I developed pain in my hands practically overnight where I can't even open a jar. Is that arthritis or a side effect of Trikafta? I've had insufferable pain in my shoulder and lower back. Is that osteoporosis or from antibiotics? My menstrual cycle is more erratic and I have terrible cramps. Is that perimenopause or my GI system or both? Those of us who are fortunate enough to age with CF are reaching middle age and beyond, and many of us are wondering how CF affects the various body systems throughout the aging process. Does it look different for those with CF versus those without? If I need palliative care, does that mean my health is declining to the point of no return? Unfortunately, these are questions that may not have answers yet. Our cohort have been pioneers in surpassing milestones like pregnancy, parenthood, menopause, and other aging comorbidities. Often we do so without data. We hold hands with our providers and jump into the unknown. We are the data that will inform the next generation of adults with CF. This is a huge topic, and we likely will not hit everything during this talk, but I am so excited to introduce this incredible panel to discuss it with. Now I'd like to introduce our first clinician. Raksha Jain is the Associate Professor of Pulmonary and Critical Care at the University of Texas Southwestern and Director of the Adult CF and Bronchiectasis Program. She has a long-standing interest in sexual and reproductive health, with a special interest in estrogen and its impact on inflammation, pregnancy, and bone health in CF. Please welcome Raksha.
Thank you so much, Melissa, for that wonderful introduction and for sharing your story. And thank you all for joining us today. I'm so excited to have a few minutes of your afternoon to get to talk about this really important topic. So today I'm really going to be going over, as Melissa said, a little discussion about sex hormones, menopause, and bone disease in the context of CF. These are my disclosures, none of which relate to the content of the presentation today. So to begin with, I'm going to start by talking about sex hormones in females with CF. And when we talk about sex hormones, there's many of them. I'm going to frame this discussion a little bit around the two main hormones we tend to talk about, and that is estrogen and progesterone. So in general, sex hormones, including estrogen and progesterone, are actually quite similar in people with CF as they are in the general population. And importantly, when you look at this graphic on the top right, where estrogen is in purple and progesterone is in green, that this time frame, actually before that black bar, vertical bar, is the time period of reproductive health when women's hormones are cycling up and down. And these hormones will cycle at times of ovulation, etc., and also change during pregnancy. But you can see that once a woman starts to hit the time period of menopause, both of these hormones will start to decline. And we're going to talk a little bit more about that in a second. Also importantly, there's been a lot of work around, or the beginnings of work, looking at is there an association between these hormones and things related to CF. And some of this comes from some outcome data that has historically shown that women with CF do not do quite as well as men with CF when it comes to outcomes, but we don't really understand why. There has been some data that has particularly shown that estrogen, at times when it's high, may be associated with increased inflammation and increased exacerbations. And when you look at this graphic on the bottom right here, you'll see that this was a graph taken out of a paper published by a group in Ireland in the New England Journal of Medicine. And they showed that in this red dotted line here that's tracking estrogen levels, and then these blue bars that's tracking onset of exacerbations, that they found that these exacerbation onsets really peak at times where estrogen is peaking. Now, understanding more about that, or more about the context of that now in relationship to new therapies such as Trikafta and highly effective modulator therapies, we don't know. So there's much more to learn about this. In addition, speaking of Trikafta and modulators, there is not known to be an interaction between these modulators and sex hormones per se. Now, the exception to that is lumacaftor ivacaftor, which is otherwise known as Orkambi in the United States, that there is thought to be an interaction, particularly between hormone contraceptive therapy and Orkambi. So one would want to find a different form of hormone contraception if you happen to be on Orkambi. So now moving a little bit into what we know about sex hormones in males with CF. So as opposed to what I just mentioned about females, there has been some data that shows that there can be low testosterone levels, particularly in males with CF. We call this low testosterone level hypogonadism in men. And the symptoms of this can be pretty significant. If you look at this clipboard over here on the right, some of these symptoms can include decreased sex drive, loss of muscle mass, reduced energy level, reduced strength, sleep problems, increased breast size, loss of body hair, and even emotional instability. So not insignificant. Now, who and why that occurs within CF, we don't know, but there was at least one study in young men with CF that showed that approximately 25% of them had low testosterone levels. Now, again, this has not been repeated in the newer era of CF, particularly in the context of modulators. So again, something we have to learn more about. And I think the other important thing for you all out in the audience to know is that there are currently not any screening guidelines about this within CF. And so if this is something you're concerned about, it's something you should definitely talk to your CF team about, your primary care doctor about, an endocrinologist, et cetera. And also know that if you're going to have testosterone levels measured, it's important that these are done in the morning and not at a time of acute illness so you can get accurate measurements. So now moving a little bit into what do we see in relationship to these hormones as people are aging. This is just kind of a nice graphic that shows in the bottom x-axis here, age over time. And this vertical axis shows the percent of hormone production in men in the blue and in women in this kind of orange-red color. And you can see that estrogen in these women in particular, it peaks in the reproductive years in general, though I mentioned it cycles. But as a woman may hit the time frame of menopause, which tends to span 40 to 50 or even older years of age, that this rapidly and steeply declines. In men, similarly, the testosterone will be peaking around the 20s and 30s, but then have a little bit more of a gradual decline over time. And we'll put that in a little bit more context, and specifically in this next slide, look a little bit at menopause. So menopause has been really tricky. And, I acknowledge right up front that this is, a challenge to even understand the symptoms and what to do about it in the general population. But it's even harder, as you guys might know, in CF, when some of these symptoms, as Melissa mentioned very nicely in her introduction, are hard to decipher what is related to CF, what's related to natural menopause and aging. So I think we have much more to learn. But just to talk a little bit about menopause generally, per definition in the books, if a woman has gone 12 months without having her menstrual period in an appropriate age range, you would call this menopause. The timing of this in general is around 45 to 55 years of age. But the timing of this within CF, we have no idea yet. So we have much, much to learn about this. When it comes to the symptoms, some of them overlap a little bit with what I mentioned about hypogonadism in men earlier. But if you look at it, they can be really variable. Some of them can include, in this top right, you'll see these pictures of mood swings, sleep disturbances, irritability, hot flashes, which I think is the classic one we hear about, headaches, difficulty concentrating, loss of libido, and joint pains. So not insignificant. Many of these can be really debilitating to day-to-day life. Has there been any understanding of what menopause does to lung disease as a whole or lung function as a whole? There's been very, very minimal. There was one study out there in the general population that actually showed that the time period of menopause was associated with a bit of a lung function decline in general in women, but this was thought to, they did not know exactly why, and some of this was thought to be connected to bone health, that as the spine starts to curve a little bit, you can lose some amount of lung function, and that was the hypothesis put out in this paper. But there's been really little further work to understand this, and again, really little to none within the context of CF. So then this brings the topic of hormone replacement therapy. So I'm sure as some of you may be experiencing symptoms like this and wondering, are you going through menopause, et cetera? First off, I encourage you to talk to your doctors, and that may include your CF clinician. It may include, again, your OB-GYN doctor, endocrinologist, et cetera. But this is really important that if you're having some of these symptoms, you want to start a discussion about hormone replacement therapy. And the reason I say that is there are different types of hormone replacement therapy. And on this chart on the right, there's some information that may have a lot more details than you need, but there's combination therapy, which includes estrogen and progesterone, and there's estrogen alone therapy. And the key to both of these is what they can do is help relieve some of these menopausal symptoms. They can help relieve some of those hot flashes. They can help relieve some of the mood swings, et cetera. But with that can come some risks of these different therapies. And so those can include things such as blood clots, et cetera. So it's really important to weigh the benefits with the risk. And in general, the recommendation is to use the lowest effective hormonal replacement therapy dose you can use for the shortest possible time to improve symptoms, to potentially improve bone health, but balance that with some of the risks that some of these individual therapies may have. And this is why you really want to talk to an expert in this to make sure that if this may be beneficial to you, that you've put this in the context of risk factors that you as an individual might have. So that moves me a little bit into the bone health field. And so when it comes to CF-related bone disease, the reason I brought this up in this discussion is that, again, sex hormones relate to this topic. So the left graphic over here describes some of the risk factors or contributors to bone loss in the context of CF. And this came out of a nice paper that was published. Now it's been quite a while ago, over 10 years ago, but some of this has not changed, where one is highlighted in this red box that low sex hormones or sex hormone insufficiency can contribute to bone loss or low bone density. Other things such as malnutrition, pancreatic insufficiency, low vitamin D, diabetes that's not well controlled, frequent steroid use, or chronic inflammation. These things can also. But, nicely, at least in this context, there are actually screening guidelines within CF, which are terrific. And these screening guidelines can start as early as the age of 8. And that's because this bone health becomes so important at a very young age in CF. So people are screened by a test called a DEXA scan. This is a bone density scan that can give someone the density of the bones and help understand bone health. And how often to screen depends on what those results are, and what you can do about that also depends on the results. But some of those can be as simple as optimizing nutrition and calcium and vitamin D. Others can be minimizing steroid use as much as possible. And there are actually even therapies. And you'll see on the screen here this therapy called bisphosphonates, which had historically been one of the first-line therapies. But now there are actually many, many newer therapies for osteoporosis in particular. So I highly encourage you to talk to your team, again, whether it's your CF team, a primary care doctor, in this case, endocrinologist, sometimes renal doctors, and sometimes mineral metabolism doctors can all have great expertise in this field and get you in the right direction when it comes to bone health. Because the key is, as you get older, we all know that people fall at times. You don't want to have fractures or things that really make life more debilitating and painful. So this has some preventative measures and screening that you can think about. So on this final slide, I didn't want to end this topic without also bringing up gender-affirming hormone therapy. I know I framed this discussion thus far in a very binary fashion and talking about men and women, but I very much acknowledge that gender is not binary, and gender-affirming hormone therapy is something that we also have to have on our radar, particularly in the context of CF. As many of you know, that having gender dysphoria is really challenging, particularly on mental health for people, and this includes people with CF, and gender-affirming therapy in general can be really beneficial. And this can include gender-affirming hormone therapy. If you look here on this graphic on the right, trans women, for example, as part of their gender-affirming therapy, may choose to use hormone therapy, which can include things like estradiol, which is estrogen, other therapies like spironolactone. Trans men may use hormone therapy, including testosterone, or even non-hormone therapies such as chest binders. And I already mentioned earlier in the discussion that some of these hormones, including potentially estrogen, may have an impact of health in the context of CF. And others of these, such as chest binders, may impact people with CF by potentially not allowing expansion of the lungs as much as we would think they should be, but we really don't know this yet. The only thing I can really tell you is out there is there are 2 case reports in the context of CF of trans women who were starting on estradiol therapy who did have an increase in exacerbation and even new growth of Pseudomonas, but these are only case reports. We really need to study this as a community to help guide people who need gender-affirming hormone therapy. And I think that it's just something that along the context of this, there's much, much more to learn. But please talk to your teams, because I think all of these topics are incredibly important to the quality of your life. So thank you for your time.
Thank you so much, Raksha. You know, over the past few years, I was on the board for CFRESH, which is the Cystic Fibrosis Reproductive and Sexual Health Collaborative. And for me, it was eye-opening to see how far we've come in sexual and reproductive health, but also how much we need to learn about how CF intersects with it. I mean, things that I didn't even think of. So I really appreciate you bringing all of this to light. You know, when I first had my first child in 2004, my care center sent me to an OB who was considered an expert in CF because she had delivered 1 or 2 other patients' babies. So, you know, we heard about the Trikafta boom on Thursday night, and I'm just still blown away about how far we've come.
Absolutely.
Yeah, but now that I'm on the precipice of perimenopause, like, again, I find myself having to educate my women's health provider on the very little we know about how CF might uniquely affect menopause. So you're right, research needs to be done. So we have some questions for you. The first one is, what are some differences in how you care for someone over the age of 40 with CF versus a younger adult?
Oh, that's a terrific question. And I think you highlighted the key of all of this already, which is this is really new territory for all of us. And, you know, I can't say that we have methodical guidelines on what to do yet. I hope that is coming here in the near future as everyone is, you know, ideally having better health and this is becoming a more important topic. I think I myself, when I think about my practice, most of it focuses on screening. And that is because, I think as you'll hear about more, there's all sorts of new areas to think about. I touched on only a few of those, but, this includes cancer screening. This includes all sorts of different screening. But, I brought up bone health, which is another one that is so important. So a lot of it is we reframe our discussions a little bit about, we're thrilled that people have gotten to this point. Our goal is to continue for people to have a high quality, long life. And a lot of that comes in screening. But how to screen within the context of CF, we're not there yet, and we don't know. I think a lot of it is, again, getting some expert subspecialty providers. Still at most centers, a lot of the CF care providers are pulmonologists like myself, and we really need to collaborate with other physicians to teach them about CF, to learn their expertise. And I think that's using a lot of our subspecialists. I know on campus now, our mineral metabolism doctors, they focus on bone health, they are now becoming much more, apt in the CF world and understanding it better and starting to recognize this is an important topic. Our endocrinologists, I think, have been there for the last several years when it comes to diabetes. Our gastroenterologists, I think, as you're going to hear about more today, are becoming aware that there's more screening guidelines. And again, as you already highlighted, our OB-GYN doctors, I think, are floored at the fact that they too used to see, one pregnancy a year. And at our own center, I think there's been more than 10 and maybe even more than that in the last year. Wow. So I think it's really collaborating with our subspecialists and having an open, upfront conversation with people with CF that we don't know, and we're going to have to involve other people. We're going to have to think about screening and being proactive. And I think the last topic I didn't even touch on is cardiovascular disease, which, I think everyone in the general population too has to think about this. And we have no clue yet, what this is going to look like in CF. And so we just have to be on the alert. And some of that's promoting healthy habits, but some of that is going to be, sort of bringing in the people that have expertise in this to help us.
Yeah, I mean, that's something that I've been hearing about lately is cardiovascular. And, I think about how I didn't even realize that, my pulse rate, let's say, is so much higher than, let's say, my husband's. And that's because our hearts are working harder to get the oxygen around. And, so obviously, I'm sure CF has a role in that as well.
Yeah, great point. And whether or not we should be screening differently, we don't know. So I think that's all the things we'll have to figure out. And sharing what we're learning with other centers and having open conversations with patients. And again, bringing these people with expertise into the world of CF. Right.
Obviously you talked about osteoporosis and another, new phenomena, I don't know if that's a weird word, but, now with Trikafta, we're seeing a lot of weight gain in patients. And one of the questions that we have is, how does obesity affect osteoporosis?
Yeah, that's a good question. So, we don't know the answer well. And I think the challenge is, especially for adults, that bone health is ongoing and remodeling throughout your whole life. And so now, we don't yet know enough about what Trikafta is going to be doing to the bones, but there is an ongoing study out there that's being supported by the foundation as part of the large PROMISE study looking at bone health pre and post Trikafta. So we'll learn a little bit about that. But the obesity question in particular is challenging because in general, it's actually malnutrition that impacts bone health poorly. But if you swing to the very opposite end of actual true obesity, that starts to impact hormones and other aspects that we really don't know enough about. We do know if someone gets, significantly obese, that the spine or the vertebra can actually be taking quite, significant weight from that. But whether or not a few years of that or many years of that is really the problem, we don't know. So I think that's a terrific question and something we'll probably start to see, over the next decade or so.
Right. Well, Raksha, I want to thank you so much. We obviously have more questions for you because this is a hot topic, but we'll bring you back on later.
Thank you.
Thank you. And now I'm going to introduce our next speaker. Dr. Dio Kavalieratos is an associate professor and researcher at Emory University, whose work focuses on improving healthcare services and outcomes for people living with serious illnesses, such as CF. He has been involved in CF-related research since 2013. He is leading the INSPIRE CF clinical trial of palliative care in CF, the first of its kind in CF or any genetic illness overall. He led the development of the CF Foundation's 2020 clinical practice recommendations regarding palliative care, and now leads the committee to develop recommendations for CF as pain management. Dio, can we bring you on?
Good afternoon, everyone. Let me share my slides really quickly. All right. Let's see here. Can you all see slides yet? Let's try this one more time. All right, I believe you should be able to see slides now. Let's go ahead and get started. All right, so thank you everybody for having me. Like Melissa mentioned, my name is Dio Kavalieratos, and I'm really excited to be here with you all this afternoon to talk about palliative care. Really, I want to take the time to talk about what palliative care is, but spend some time really talking about what palliative care isn't. We're going to dispel some myths because there's a lot of misconceptions out there about what palliative care is or isn't. And I want to spend time ending the talk really making sure that people leave today's session knowing when palliative care might make sense for them. So in terms of disclosures, Melissa mentioned most of them in terms of my involvement with the CF Foundation and leading the first palliative care trial in CF. So let's get going. So what is palliative care? So I like to say that palliative care is an extra layer of support that helps people live with whatever serious illness they're living with, despite the illness itself and the treatments and the complications that might come with it. And so how does palliative care do that? So really it involves looking at the person as an overall person, right? So what are the different components that come into the experience of living with a serious illness, and looking at how do we improve and maximize quality of life and reducing suffering, again, related to the illness itself, as well as the treatment and the treatment burden. And how that actually plays out in day-to-day life is being on top of physical and emotional symptoms and managing them to the best of our abilities. And that might include prescribing medications or non-pharmacological therapies, having important and sometimes difficult conversations to make sure that the healthcare that somebody is being provided with matches what matters most to them, matches their goals, their values, their preferences, and even their fears about the future. All the while, we know that people who are living with CF don't often live in isolation. They have families, they have friends, they have support systems around them. And we want to make sure that those caregivers and families are supported as well so that everybody functions well as a unit. So first myth that we want to dispel is the difference between palliative care and hospice. Oftentimes when I introduce palliative care to somebody, they say, wait, my pulmonologist didn't tell me something. What's going on? Am I dying? I've heard of palliative care, but I think that's what happens then when you're dying or when you're much older. And I'm here to mention that palliative care is appropriate at any stage in the illness experience. What hospice is an intense form of palliative care for people who are expected to live less than 6 months if the disease runs its expected course. Hospice is mandated by Congress as a specific type of service, and it's a type of palliative care, but it's not all palliative care. This is a nice figure that I like to throw up sometimes. You can see the large circle being all palliative care, and hospice is just a specific but really intense form of palliative care, whereas palliative care overall can be delivered at any point in the illness trajectory. So next, really importantly, who provides palliative care? That's another big question that we often get. And what I like to say is that palliative care requires a team approach, and that CF care teams are at the core. I was going to go into quarterbacks and whatnot, but I am not the person to go into sports analogies. So we're going to leave it as that CF care teams are always going to take the lead in what I call providing primary palliative care. So what is primary palliative care? That's really, again, sort of having the closest experience to the person living with CF and their loved ones to pick up on things like assessing unmet symptom and quality of life burdens. Really, so when you're going in for your quarterly outpatient CF visits, seeing over time that maybe shortness of breath is getting worse over time, maybe cough is getting worse over time, or having, again, those communications about treatment options and alternatives. Are we thinking about a modulator? Are we thinking about transplant? Are we thinking about X, Y, and Z? But really being that frontline clinician or provider to make sure that that person living with CF and their families are functioning as best as possible and picking up on those needs. But importantly, knowing when a burden or a symptom or a communication need expands beyond their capacity or their training or their comfort, and knowing when to refer out to somebody else, or making sure that those needs are met as a team approach. And that's where palliative care specialists come into play. So they're the ones who provide expert level management of those complex needs, whether they're symptoms, whether they're communication needs, whether they are getting somebody the services or supports that they need to live the best quality of life possible. One thing I'll mention is that palliative care specialists can be pulled in either while somebody is in the hospital, or oftentimes, and we're seeing this more and more across the US, that palliative care outpatient clinics can often be open to people living with CF, or palliative care specialists can be embedded within CF care centers. One analogy that I'd like to throw out here to make sure that folks understand it is the concept of, for example, psychiatry, right? So let's say I go to my primary care clinician and say, hey, I haven't been feeling well, not feeling like myself. My primary care clinician might start a low dose antidepressant. We might try 1 or 2. And if it doesn't get better, they're probably going to refer me out to an expert in psychiatry or a psychiatrist. Same concept here with palliative care specialists. When those needs, whether they're symptoms or communication or treatment needs, expand beyond the capacity or the expertise of the CF care team, palliative care specialists are always there to become part of the CF care team, not a replacement for the CF care team, but a part of the CF care team to make sure that all bases are covered. See, there I go with the sports analogies. So what do we know about palliative care? What's the evidence for it? Well, overall, we know that palliative care, or a palliative care approach, improves a number of outcomes for people living with serious illness. And how we know that is that in 2016 and then in 2021, we did a series of meta-analyses. What those are a study of studies. So you take a bunch of clinical trials and pull them all together and see what happens overall. And what we found was that palliative care was found to improve a number of outcomes. Importantly, medium-sized improvements in quality of life, medium-sized reductions in symptom burden, as well as improving satisfaction with care, and a whole bunch of other outcomes. But importantly, to date, people living with CF have not been included in trials about palliative care. And like Melissa mentioned, people with genetic illnesses in general have not been included in most palliative care studies. We do have some evidence from some small or not super rigorous trials of palliative care that show that there might be some benefit in CF. But what we do know is that there's an intuitive argument that palliative care probably makes sense in CF, because we see that it has many benefits in things like lung cancer, heart failure, COPD. And so I want to put a big shout out to the CF Foundation for leading the way here. They've invested more than $5 million to date in studying palliative care. One of the trials being the Inspire CF trial, which is what happens when we embed a palliative care specialist within the multidisciplinary usual CF care team. So that would be specialty palliative care. And then there's the Improving Life with CF study, which is more along the lines of primary palliative care, which is arming and training CF care teams with tools on how to screen and address palliative needs themselves in clinic. So we see the CF Foundation is again, sort of on the cutting edge of looking at both types of palliative care, specialty palliative care and primary palliative care. So this is a complicated diagram, but I want to walk you all through it because I think it'll hammer home a number of points. So on the topic of when is the right time for palliative care, to again dispel the myth that palliative care is just for people who are at the end of life or for people who are really not doing well, I want to point out this diagram here. And what we see is this, sometimes we call it a bridge or a rainbow, whatever we want to call it today. But in the center here, you can see this white band that's we call palliative needs. So that, again, those might be symptoms, those might be communication needs, whatever it may be. And we see that that band over time expands and contracts. You know, people's needs, some symptoms get better or worse over time. All the while, in that core there, you see that people are getting their usual CF care, their high quality CF care. And they're getting primary palliative care from their CF care teams. CF care teams are asking about symptoms. They're asking about treatment goals and whatnot. So the CF care team is there on the front lines, walking the path with the person living with CF and their families, and providing that first level support of palliative care. But importantly, what we see in that purple bar above the palliative needs is specialty palliative care, or palliative care specialists. And what we see is that if you notice closely enough, the teeth of that purple band kind of sort of expand and contract in relation to palliative needs. So again, when somebody's palliative needs expand beyond the capacity or the comfort or the knowledge of the CF care team, palliative care specialists can dip in and join the CF care team in making sure that that person living with CF is living the best quality of life possible. And we see that this goes from the point of diagnosis all the way throughout somebody's entire illness journey. And that primary and specialty palliative care work in tandem. So let's end today's talk talking about some concrete sort of takeaways of when might a palliative care specialist make sense? When might you think about asking your CF care team to refer you to a palliative care specialist? So again, when somebody's symptoms, either physical or emotional, are out of control and they can't be met with that first-line therapy that a CF care team might provide. When somebody might be a little bit unclear about what to expect in the future, whether that is, what could I expect if I were to go down the path of a transplant, or if I were to start a modulator, or if I were to X, Y, and Z. If there's clarity about the future, a palliative care specialist can come in and work with the CF care team and provide that clarity to people living with CF and their families. Again, when making difficult or complicated treatment decisions, to know what to expect in the future, to know what alternatives there may be, or to have a third party to just bounce ideas off of and have a safe, neutral space to decide about those options. When there might be disagreement among your care team and among your family, again, for a third party to come in and help navigate that disagreement and provide clarity. And all in all, to make sure that people living with CF and their families or their support units have the most support that they need to manage the stress of living with CF and live the best possible quality of life. And again, to reiterate the point, palliative care can be requested at any point in someone's illness journey or someone's health. So thank you so much. Happy to take questions.
Wow, Dio, that was a lot of really great information. And I have to admit that until I joined the Improving with Life with CF palliative care study, I always thought palliative care meant hospice care and thought it was a really scary term. But I've learned a lot working on that study, and even more just listening to you here today. And I feel like we've been meeting now for the past like 2 months. And one thing I love is that they're including caregiver screening, as chronic illness affects more than just the patient. So that's really important. Okay, the first question that we have for you, aside, is how we can debunk the fear, especially for aging adults, that palliative care does not equal the end of life, so that patients will actually seek it out.
That's a really great question. And, you know, this might sound like a really reductionist answer, but it takes communication. It takes blunt communication. So, for example, in our Inspire CF study, when we're enrolling people living with CF into the trial, we start by saying, this is a trial about palliative care. What have you heard about palliative care? And that opens a conversation for people to say, for example, oh, well, you know, I know somebody who had palliative care, but they were dying. And then we can jump in and say, actually, that's not what it is. And so what I would say to folks in the audience is, don't be afraid to ask the questions, and don't be afraid, for example, to get online and look at, for example, getpalliativecare.org or other palliative care websites to understand what it is and it isn't. But again, what it requires is communication about palliative care and how it fits in the life of somebody living with CF.
Okay, so this is something that we can seek out for ourselves, not just necessarily rely on our CF care team to tell us about.
Absolutely.
Okay, good. Okay, a question that came up was, now that we have modulators and people with CF are living so much longer, do we still need to be talking about palliative care?
That's such a good question, and another one that I get all the time. And what I would say is absolutely, right? So for a number of reasons. So, you know, for example, people who are on modulator therapies might still be having symptoms. We know that people who are on modulators don't have all of their symptoms fixed just by virtue of being on a modulator. We know that there are symptoms that come up that they didn't have before, or persistent symptoms, and that they could use help managing. As well, we don't know what the future does concretely look like in the face of modulators. And so there may be uncertainty, there may be fears. As well, everybody is going to face an aging process. All of us are going to get older. All of us are going to face some concrete future and mortality in front of us. And so when we get to that point, palliative care can be there waiting. But importantly, palliative care is also there waiting for us along that entire journey, whatever happens in between there.
Right. And I do also want to remind everyone that 10% of people with CF do not have access to modulators, and some who have access to modulators can't tolerate them. So
absolutely.
Exactly. All right. As well, we have questions for you that we'll take at the end, but I'm going to introduce our next speaker. Thank you so much, Dio. Our final speaker is Dr. Linda Cummings. Dr. Cummings is a gastroenterologist who sees adult patients with CF at university hospitals in Cleveland. In 2019, she completed a 3-year program sponsored by the CF Foundation called Digest, which educates gastroenterologists in the care of people with CF. So please welcome Linda Cummings.
Thank you, Melissa, for that introduction. I'd like to thank the CF Foundation and the organizers of ResearchCon for inviting me to speak about GI cancer screening and cystic fibrosis, and I'd like to thank the audience for participating. Next slide, please. These are my disclosures. I have listed some grant funding, which is unrelated to cystic fibrosis, and I will be the site investigator for an upcoming study sponsored by the CF Foundation called NICE-CF, which is going to look at stool-based testing for patients coming for colonoscopy for colon cancer screening. Next slide, please. So cystic fibrosis is linked to a higher risk of digestive tract cancers. And what you can see in the upper part of the slide is that there's an increased risk of colon and small bowel cancers combined using data from the CF Foundation National Patient Registry over a 20-year period. And when they looked at these combined cancers in the colon and the small bowel, what they found was that the risk was higher in patients who had a more severe phenotype. That is generally people who had the F508 homozygous genotype. And when they looked more closely at the risk of colon cancer and compared to people who do not have cystic fibrosis, they found that the risk of colon cancer was about 6 times higher than expected. The blue lines in the diagram refer to where the colon or large intestine is. That's the shorter blue line. And then the longer line is showing where the small intestine is. And then in the red box, I'm highlighting the point that there was a slight increased risk of cancers where the esophagus and stomach meet. But the actual numbers of these cancers was very small. And then in the lower half of the slide, you can see kind of a representation of a colon polyp. And there's data mostly from University of Minnesota, which shows that colon polyps, which we think are kind of the precursors to colon cancers, appear to be more common in people with cystic fibrosis. This increased risk of colon cancer has led to recommendations for colorectal cancer screening. Next slide, please. So in 2018, the CF Foundation, along with one of the GI societies, published screening recommendations for colorectal cancer in people with cystic fibrosis. And they had 10 major points that a task force actually had to have enough agreement on. And there were several members of the task force who were gastroenterologists, there were pulmonologists, there was a parent of an individual with cystic fibrosis, as well as an adult patient with cystic fibrosis, and there were statisticians. So I've tried to boil this down to 6 points, even though there are actually 10 in the recommendations. One is that the decision to proceed with screening for colorectal cancer should be involving shared decision-making between the patient and the caregiver, with consideration to the patient's treatment, their other medical conditions or comorbidities, safety, since the procedure does have some risk to it, and their overall goals for their quality of life. The second point is that colonoscopy is the recommended way of screening for colon cancer in people with cystic fibrosis. And the main reason is that there just is not enough evidence in terms of other screening tests that have been looked at in people who don't have cystic fibrosis, such as stool-based tests or CT colonography. There is an upcoming study called NICE-CF, sponsored by the Cystic Fibrosis Foundation, which will be looking at stool-based testing in people who are getting colonoscopy for colon cancer screening. The third point has been that patients should start screening with colonoscopy once they turn 40. The screening should be done every 5 years if no polyps are found and if the colonoscopy is done and the person performing the procedure was able to get a good look, as in the prep was okay. Transplant patients should start at age 30 once they've recovered from transplant within 2 years of transplant, unless they had a negative colonoscopy within the past 5 years. And they should continue every 5 years as long as no polyps were found. If any polyps are found on colonoscopy, whether or not the patient has had a transplant, they should have a repeat colonoscopy in 3 years. However, this interval could be shortened if more than one polyp is found or if there's a lot of debris in the colon. And that brings me to the last point, which is that an intensive bowel prep is needed for the procedure. So my center tends to use the University of Minnesota bowel prep, which involves taking 6 to 8 liters of a large volume of prep. And it's actually spaced out, so it's multiple washes over a day and a half in order to provide the best prep. It's especially important to examine the right side of the colon because in this study looking at the CF Foundation patient registry, where they actually tracked down details regarding the colon cancers that were found, it seemed as if more of the cancers appeared on the right side of the colon. And in general, when you take the bowel prep, it starts working on the left side of the colon before it starts working on the right side. Also, in my experience, I found that a number of my patients have actually had polyps at the end of their small intestine. So I always make a point of looking in the end of the small intestine at the time of colonoscopy, although that isn't written in the recommendations. So in my experience, generally patients do need an intensive bowel prep. It's possible that people who do not have pancreatic insufficiency may potentially not need as intensive a bowel prep, but really more research would be needed to know if that's really the case. Next slide, please. So this slide is just a reminder to everybody that the definition of screening really means that a patient is not having any symptoms. I've posted on the right some red flag signs because it can certainly be challenging in somebody with cystic fibrosis who may have some gastrointestinal symptoms from time to time to know what's really more alarming. So one possibility would be a low blood count or anemia. And in some cases, this can be due to the loss of blood in the gastrointestinal tract. And this can occur slowly to the point where the person might not even notice that they have any blood in their stool. There can be other causes for a low blood count, though, so it could require some other testing. And then I've divided these other red flag symptoms into lower gastrointestinal symptoms in which a colonoscopy might be needed regardless of the person's age. So, for example, bloody stool is not normal. And then upper GI symptoms. And I bring these up because it's possible that somebody may actually need an upper endoscopy, which is a procedure where we take a look with a flexible tube with a camera and light on the end of it. And we take a look going through the mouth to look at the esophagus, stomach, and the first part of the small intestine. So black tarry stool can be a sign of blood loss in the upper gastrointestinal tract, although certain medications like iron and Pepto-Bismol can cause some black stool. Trouble swallowing and painful swallowing, those are also some red flag signs that could warrant an endoscopic procedure even if you're not yet 40. Next slide, please. So I'd like to thank the audience for your attention, and I've posted here a screenshot from a video that explains the risk of colorectal cancer and cystic fibrosis, and this is available on the CF Foundation website. And it's also listed as a resource in the resource handout. Thank you.
Thank you so much, Linda. You know, as someone with CF, I find GI issues to be my most confounding and complicated symptomology. I'm pancreatic sufficient, but have suffered from chronic DIOS in my 20s and early 30s. I was on a steady diet of Golightly and mag citrate, even having to drink that on my honeymoon in Hawaii, which was just lovely. Despite that, you know, when I'm not feeling well and I have a cramp in my side, my lower back, my hip, or I'm just not hungry for a few days, I'll go through a mental checklist of all the worst possible scenarios, like you were talking about colon cancer. And somehow I always forget that it's just something like it's gas, or like I just have to take some Miralax for a few days. But it's just, you know, I always go right there because you never know what it is. It's like such a strange set of symptoms. So we have some questions for you, obviously. Should other cancer screenings be included besides just the standard for colon cancer, such as those for pancreatic cancer, stomach, or other GI cancers?
That's a good question. At this time, we just don't have enough evidence to recommend screening for other GI cancers. The data from the CF Foundation Patient Registry, looking over 20 years, did show that there was an increased risk of cancers where the esophagus and stomach meet, but the actual number of cancers was still very small. In my practice, what I tend to do is, if I know that a patient is needing a colonoscopy, I will review their history. I'll ask about symptoms and look at their lab tests and try to determine, is there some reason that they may also need to have an upper endoscopy at the same time that I'm doing the colonoscopy? In terms of pancreas cancer, there was actually only one case in the CF Foundation Patient Registry data. There was another publication that came out a few years ago, which did suggest that there was a slight increased risk of pancreas cancer. But because it's not that common a cancer, there were 9 cases over a 21-year period looking at the US and Europe. And so the actual risk for an individual patient is still very low. In fact, the authors of the paper actually wrote that in general, they felt that most CF providers probably would not see a patient who has cystic fibrosis who developed pancreatic cancer. And I guess it remains to be seen what will happen with these highly effective modulators as people are living longer, and we may need to kind of reassess this question.
Thank you. And next, considering the University of Minnesota study stating that by age 40, 50% of CF patients will have developed colon polyps and 25% of those will be high risk, why have we not lowered the screening age from 40 to ensure that fewer patients develop colon cancer?
Well, that's a very good question. I think, you know, when they were trying to develop these guidelines, they used statistical modeling. And that was looking at different scenarios of stages for screening. And they were also trying to take all the evidence that was available. So the recommendation to start at 40 is based on modeling, and it's based on the best available evidence at the time. And there just are not a lot of papers describing colon polyps in patients who are under the age of 40. So for right now, at least, that is where things stand. In the general US population, most of the guidelines have recently lowered the age to start screening to 45 from 50. So I think this is an area where we may need to do some reassessment over time. But at this point, we just don't know.
Okay. I would love to bring up all of our speakers. We are getting a lot of questions coming in, and I need to start asking them to make sure we have some time. So they are going to be sporadic, so whoever thinks they could take it, take it. All right. The first question, are there any studies of women with CF who have had a lung transplant around menopause and hormone replacement therapy? The speaker says that her doctor recommended it may not be good to be on an HRT due to being post-transplant and interaction with anti-rejection meds.
I'm happy to take that one. And that's a great question. And I'm sorry I didn't include that in my talk because there are many different scenarios and which one may not be. It may not be the best idea to be on hormone replacement therapy. And that's a great point. There is a drug for commonly used post-transplant called tacrolimus or Prograf, and that actually does have an interaction with hormones, particularly estrogen. That's a component of hormone replacement therapy. So that's a great point that in certain settings, your doctor, whether it's your transplant doctor or OB-GYN doctor, may say that's not a good idea. There are definitely still some options out there to help control the symptoms of menopause, but for, in terms of hormone replacement therapy, that may not be the best setting.
Okay, thank you. All right, well, Dio, this is for you. Does palliative care include dealing with my insurance company regarding treatment and prescription costs?
That's a great question. So yeah, oftentimes when we're dealing with, complex needs, there may be complex therapies required and complex approaches. And so, yeah, palliative care teams can be helpful in managing those. They're probably not going to be as helpful in managing sort of like frontline or sort of standard CF treatment affordability and things like that. But once somebody does start seeing a palliative care specialist and there might become sort of higher level needs, palliative care teams can definitely help sort of figure out how to navigate things. They often are experts in figuring out things like transitions of care and finding ways to afford otherwise expensive medication. So again, it's one of those things that palliative care can definitely be helpful. It's got to put your toe in the water and see if it can be.
Thank you. Okay, Linda, this is for you. I lied. I can tell who the question's for. Linda, since some people can't tolerate the prep for a colonoscopy, is there another way to prep for the colonoscopy? And I'm going to add a part 2 to that. Are there any other screenings for colon cancer aside from colonoscopies?
So tolerating the prep is kind of a challenge. One thing that we have found outside of the CF population over the past few years is that it's a better prep actually when people split up the prep into multiple washes. In some cases, that can help somebody tolerate a prep better. Other things I've tried in people who, not necessarily patients who have cystic fibrosis, is to give them an anti-nausea medicine before they even start their prep. There is a new prep out there, which is only pills, and it's called Sutab. I don't have any connection to this company. I have not used the prep much in any of my patients, whether they have cystic fibrosis or not. That was recently put on the market. I prescribe it rarely only because it's generally not well covered by insurance. I don't know whether it would work well in somebody who has cystic fibrosis or not. Unfortunately, at the end of the day, there's typically quite a bit of stool to clear out. What I have found is some patients who took all their prep and yet somehow they still had stool in there tended to be some of my patients who had not been taking their pancreas enzymes regularly. And unfortunately, what ended up having to happen was that we tried really hard. The patient worked very hard on taking them more regularly. And then I brought the patient back after a few months of being on the enzymes regularly. And then the prep actually was fine. The prep from the University of Minnesota does also include some pills, which is bisacodyl, brand name Dulcolax, and then magnesium citrate. But I have not had any experience trying to use, kind of lower volume, other than to say the Minnesota prep does involve 2 preps. So it's really like twice as much of that large 4-liter jug compared to the regular population. So in a select number of patients, I have tried where we did 1 jug of the 4-liter prep, and then I actually prescribed something that was lower volume, and the prep was fine. But at the end of the day, the recommendations from University of Minnesota really do say 6 to 8 liters. So if someone's having trouble tolerating the prep, I almost feel like maybe they need kind of an assessment in general of how their GI symptoms are. The last thing you want to do is to make somebody miserable by making them take all of this prep when you kind of might need to optimize other things. Is it possible that they have really, really bad constipation and they're so backed up that they're nauseated? So I would kind of want to investigate further. The other question was whether there are other methods to screen. So that is an area that really does not have any evidence right now, and that's why in the CF Foundation recommendations they said colonoscopy is the screening method. But the NICE-CF study, which will be opening in the next few months at some of the CF centers, is going to look at stool-based testing in people who are coming for colonoscopy. So they'll be looking at a test that looks for blood in the stool called FIT, and also a multi-target stool DNA test, which is looking at different abnormal cells that are shed in the stool. It's looking at a combination of abnormal cells and the presence of blood in the stool.
Thanks. And for those who did not see the GI track yesterday, I recommend replaying that because they did touch on the NICE study. Okay, so just changing courses. What is the disadvantage to measuring testosterone later in the day? And then I'm going to part two that one as well. Is it recommended for men who are aging to take testosterone replacement therapy to increase their lung function?
Yeah, so those are great questions. So first of all, when it comes to the timing of measurement, a lot of this is because hormones fluctuate in their levels even as frequently as throughout the day. And when it comes to testosterone, it actually peaks at about 8 a.m. in the morning and declines throughout the day. So it's not that someone, I know it's a real challenge sometimes to get labs done in the morning, but that's the most accurate value because it's possible that if you go and get your labs done in the afternoon and find that your testosterone level is low, your doctor may go back and say, well, can you go and get it repeated in the morning to make sure it wasn't just low because it was later in the day. So that's really why that's done, is because there is a fluctuation even throughout the day. The second part on, remind me, it was replacement of testosterone and whether that impacts lung function.
Right.
Okay. So, you know, there are definitely people out there who take hormone replacement therapy for testosterone. And I would say when it comes to replacing a low level of testosterone, that is a good thing to do. That you know, having, as I mentioned, having hypogonadism or low testosterone can cause some really, you know, unfortunate symptoms for people when it comes to quality of life. If this changes lung function, I don't think we really know that. That has not been studied. And I think it's a terrific question. I think one thing I would just caution, if your testosterone level is normal, taking additional supplemental testosterone is not yet recommended in any way. We don't know the implications of this. And I know there's people who sort of associate having a higher body mass with better health, which has been the tradition in CF. But I think using a supplemental hormone above and beyond what is normal, we don't know the implications. So I would just caution you that if that's something you've been thinking about, again, talk to an endocrinologist, talk to your CF team, et cetera, and really find out the nuances of it. Because, you know, as you know, altering things that are normal in the body can have side effects that we don't learn about for many years down the road.
Okay, if I can just stay on the hormone track here, there's another question for you. And that is, can you speak more about progesterone and progesterone-only hormone replacement therapy?
Oh, that's a good question. And I didn't bring that up largely because that's not traditionally one of the options that are discussed, but it is important and probably even more important in the CF context, because the typical time that one would consider using progesterone-only therapy is if you have a contraindication to estrogen therapy. And there are some, and I wouldn't say contraindication, I would just say think twice about it because everybody's different. But one of those, when it comes to estrogen, some of the concerns about estrogen are that it can be associated with clot risk for somebody. So if you've been somebody that has had blood clots in some way, your doctors or team may be concerned about you being on estrogen and suggest a progesterone-only based therapy. Another one is significant liver disease, that sometimes in the setting of significant liver disease, someone would not want to be on estrogen. And I think the reason it's not brought up is for many years, it wasn't clear whether progesterone only would actually help some of the symptoms of perimenopause. But I think more and more there is a thought that it can be helpful. So, you know, I think if you're worried that estrogen may have some of these side effects on you, again, talk to your team, and progesterone only therapy might be a very reasonable option.
Okay, great. Okay, Dio, this one is for you. What is the role of palliative care for people going through the transplant experience and after?
That's a really great question. So in 2020, the foundation put out clinical practice recommendations for palliative care and CF. And a couple of the recommendations did hit squarely on the transplant experience. So for example, the foundation recommends that anybody considering undergoing a transplant or chooses to decline a transplant, see a palliative care specialist. So again, discuss those options and weigh out the pros and cons, and again, create a treatment plan that reflects their goals, values, and preferences. There's also, I'll mention that there's not much research about sort of what palliative care sort of structurally should look like in the post-transplant experience. We know that the post-transplant experience can be very variable. Everybody is different. And so there's probably not a one-size-fits-all. I will say that we're embarking on doing some research in that area. So we have a grant under review right now to really understand from a stakeholder engaged perspective, sort of when should palliative care clinicians be involved and how do they complement the CF and transplant care teams. So all that to summarize, we don't have sort of concrete evidence right now, but what we do have is the recommendations from the foundation saying that yes, palliative care should be involved in the transplant experience, either if you undergo it or if you choose to decline it.
Yeah, I would think so. I think that this decision requires a lot of support that you guys could offer. So thank you for that. This is an interesting question. Linda, is there an increased risk for colon cancer for CF carriers? I don't know if you have an answer for that, but.
At this time, I don't think that I've seen any papers commenting on an increased risk, and the CF Foundation colon cancer screening recommendations, which was published in 2018, stated that they did not know whether people who just have one CFTR mutation have an increased risk or not. We think that the gene is probably something called a tumor suppressor. And if you look up a tumor suppressor in general, you have to have two mutations in a tumor suppressor for your risk to be increased. But again, like I have not come across any papers showing that someone who's a carrier would have an increased risk of colon cancer.
Okay, thank you. This is a question that's near and dear to me, and I'm going to tie it into a second question also. And that is, how do you determine whether night sweats are due to an oncoming exacerbation or menopause? Something that I have definitely asked myself 100 times. And in that same regard, is there a way to tell if you're in perimenopause or menopause? This person writes this, particularly if you're on a hormonal birth control to prevent menstruation, which makes it really tricky.
Okay, great questions. So first of all, I'll acknowledge right up front, the question about the night sweats is very challenging. And I think, many people probably have the same one, and we have the same one when people come to us as well. I think a couple tools you can think about is if the chronicity or the time frame at which you're having these night sweats continues for a long period of time, then, it's then obviously, and you're in the age range where you could be going through menopause or perimenopause, then think about it. It's possible that it's more menopause related. But, and the other thing is to use other clues. If you're, suddenly not sleeping well, if you have mood instability that you haven't had in the past, again, those are other clues that would more support menopause. And I think if you've got clues that are more saying, okay, I feel a little more congested, I'm coughing more, et cetera, then you would sort of waver on the exacerbation side. And the tricky thing is you don't want to sit on this, because if you're having night sweats and you're worried you might be sick, you don't want to just wait a couple months and say, oh, okay, it's lasted long enough. So I think that, I'm not giving you a great answer other than to say, waver on the side of reaching out to your team, and maybe they'll say, hey, come in. And, one, we can see if you're doing well from a lung function, et cetera, standpoint. The other thing is there is a way to measure perimenopause, and that is there are a number of different hormones that can be measured. I just focused on estrogen and progesterone today, but there are several others, including a hormone called LH, luteinizing hormone, FSH, et cetera. Put in the right context and done at the right time. If these hormones are checked, it's actually very helpful in guiding, I think endocrinologists or reproductive endocrinologists in particular are very good at this. They can check these levels and really help kind of get a sense of, yeah, it does look like they're getting into the time frame of which you might be reaching this. And when it comes to if you're on a hormonal birth control and you're wondering about this, the nice thing is these hormonal birth controls are different. There are different types of estrogen in the body. And the estrogen that is often measured is a little bit different than the estrogen that is given through hormonal birth control. So you can still, and granted, hormones, endogenous hormones, or the hormones you produce in the body are suppressed by hormonal contraception, but you can still get a sense of it by sending the whole panel of hormones. And sometimes it takes more than one check to know, but it can still be done. So I definitely encourage you that if you're wondering and worried, you can have some of this testing done to help at least get some sense. It's not always perfect, but you can get a better sense of what might be occurring.
Okay. Yeah, that is, I've woken up sweaty and wondering what is going on a few times, many times. Okay, we only have time for one last question. I know there are many more that have come in, and I encourage you to reach out to your physicians, or next, Raksha and I are going to be doing a Meet the Experts if you have any questions that are geared toward her. But the last question I have for you is, what studies have been conducted on CF patients who are seniors? I'm guessing it's a small number, if anyone even knows. I think
the silence is saying something here.
Yeah.
I'm kind of scratching my head, honestly.
Yeah, I don't know of any studies specifically. I mean, I know that there are studies that have people who are of older age in them, but specifically, no, that's definitely a gap that we definitely need to focus on from an equity standpoint, for sure.
Yeah, I agree. And I do think people have this on their mind now, and we'll see some over the next several years. But I agree, we have not done a good job at getting in front of this topic as we maybe should have.
Okay, well, folks, we have 3 researchers who are hearing you and are going to jump on that. So I want to thank you guys so much for being part of this panel. Like I said, I was so excited to talk about it. As someone aging with CF, I selfishly created this topic. So thank you so much for being a part of it and for giving your time on a Saturday.
Thank you.
Thank you for organizing it, and thanks for the comments from everybody in the chat.
Yes, thank you so much.
Okay, thanks to all of you guys for your attention and your questions. I'm grateful that we have begun this conversation, and I hope it will continue, as there are clearly areas we did not cover, such as mental acuity. I know I'm not the only person having memory issues and word recall since starting modulators, or is it because I'm 48, or is it perimenopause? My arthritic pain started when I was 46, but also a month after I started Trikafta. When I turned 40, I developed a rash and a sensitivity to yeast, wheat, and dairy. I tested negative for celiac, though my son tested positive. But what is that about? We didn't have time to touch on autoimmune issues in people with CF as they age, but researchers are starting to look at that. And of course, attention must be paid to how transplant and transplant medications affect these issues as well in people with CF. So as we've stressed, many of our questions on aging do not have definitive answers, as you just clearly saw our last question. It's our individual and collective stories are what will drive this research. I hope one thing that you take away from this is that we as adults with CF need to share our experiences and to be sure to ask questions of our physicians. I want to extend a huge thank you to the providers who listen to our concerns, are honest and open about what they know and what they don't know, and are willing to partner with us to search for answers. I also want to give a huge shout out to adults with CF, including but not limited to Emily's entourage, Dr. Zan Nowakowski, and the members of CFresh, who have identified research gaps and then pursued innovative research to fill them. I want to share advice that Raksha gave us during our discussions. When you go to a specialist who may not be familiar with CF, talk with your CF provider and discuss a list of questions or resources about CF that you can bring to your specialist so that you have a better understanding of what to ask them and what they could be looking for. There are many wonderful resources related to all of the event sessions on the resource page. For this session, you'll find the slides that we shared and other items the speakers thought you might find valuable. Please spend some time exploring the resources and download anything that you would want to keep. We now have expo booths and networking sessions open for the next 45 minutes. In the expo, you can visit CF Foundation staff to learn about a number of foundation research initiatives, or visit one of 2 Meet the Speaker booths where you can interact with respiratory therapists, Shine on Pay, and Lathronia Jefferson from the session on managing daily care, or you can connect with Dr. Raksha Jain and myself. We will be answering questions if you have any more you want to discuss. Finally, if you are interested in meeting other ResearchCon attendees, visit Networking, which is a fun feature that allows you to connect with others and get randomly matched with other attendees for a 5-minute video conversation. This attendee could be a clinician, a CF community member, researcher, or CF Foundation staff member. You will never know who you'll get matched with. Thanks again for coming to learn about aging with CF. We hope to see you at the closing keynote about genetic therapies on the horizon, which begins in about 45 minutes at 3:15 p.m. Eastern Time. Thank you so much.